As I mentioned previously, osimertinib has very good brain penetration. In the initial AURA studies, there were clearly response and durable responses in the brain and control of disease in the brain. There was, in the FLORA trial, an analysis of progression-free survival in patients with brain metastases, those without brain metastases. The benefits seem to be identical in both. So it suggests, again, that osimertinib does have good activity in the brain. And as I mentioned previously, I think that we need to educate our radiation oncology colleagues and our neurosurgeons to make sure that we don't have this knee-jerk reflex by doing radiation first. These EGFR TKIs that have good CNS penetration do have activity that's quite substantial and can control brain mets. And it's not that you're going to never do radiation, but at least you can delay radiotherapy and also delay the side effects of radiotherapy to a time when they're in the later stages of their disease. The initial role of osimertinib was in the treatment of T790M positive disease. So patients would typically get erlotinib, gefitinib, or afatinib. The average patient would go about a year, and then they would have disease progression. Roughly 60% of those patients would be found to have T790M. Osimertinib is a very good T790M drug. And we would use it as second-line EGFR TKI after first or second generation. The problem with that, though, is what do you do with the 40% that are T790M negative? The point I think it's important to emphasize is that based on the FLORA data, osimertinib has been shown to be a better drug. So I want to get the best drug to all the patients that can benefit from it, rather than save the drug for the 60% of patients that develop T790M. And so I do think the FLORA data is compelling. This is a better drug for exon 19, exon 21 in T790M. We know T790M is the major mechanism of acquired resistance from the first, second generation drugs. If you use your better drug up front, which is the FLORA strategy, you get better outcomes, better progression-free survival, greater durability of responses. Again, I think a clinically significant trending overall survival benefit and less toxicity. So that's why I think osimertinib is your first-line choice. As I mentioned, the toxicity profile in the FLORA trial favored osimertinib versus the first, second generation drugs. Osimertinib has the advantage of being a very good mutation-specific drug, a very good T790M drug, and spares wild-type EGFR. So the wild-type EGFR that's in our gut, that's in our skin, you see less gut and skin toxicity. So my personal experience has been actually quite favorable relative to what we've been doing with the first, second generation drugs, which have more skin and GI toxicity, as well as more liver toxicity. So I think that in general, in the patients that I have on osimertinib now, they are having some grade 1 toxicities, but not the grade 2 and 3 skin toxicities we saw with the first, second generation drugs, or the GI toxicities. So, you know, again, I think it's a more active drug. It just happens because it spares wild-type EGFR. It's less toxic. So I think it's a win-win situation. There are a few situations where you need to think about using patients with prolonged QTc interval, patients with a history of interstitial pneumonitis, patients with borderline cardiac function. I wouldn't say it's an absolute contraindication to osimertinib. It should be thought about and is a relative contraindication. Sometimes patients are on other drugs that may affect the QTc. You can switch those drugs and use osimertinib safely. So I think that there are very few patients but there are a few things, as I've mentioned, that you have to kind of think twice about it. It's not that I wouldn't use it in those situations, it's just that you have to be just a bit more careful in those patients.